So, ladies and gentlemen, today is the 25th of December, and this is Dr. Saturn. I'm a doctor of physical therapy, a board certified wound specialist, and also certified in the area of lymphedema. I am here at one of the snow parks here in California, and I would like to talk about one of the most common questions that I have been asked lately is that, is it okay for me to wrap a leg while there is still a wound? Meaning to say that, is it okay for me to apply Uniboot or Coflex or whatever type of compressions when there is a wound in the leg? There was a thought or concept in the past that we need to heal the wound first and then we'll do the compression later. So there was a practice pattern in the past that if you assess a patient and they have a wound, all you need to do is to do the dressing change, debridement and whatnot. Do not apply any form of compression because the compression might cause more irritation and causes or increases inflammation to the wound that would delay the healing process. So that was the practice pattern in the past. However, if I tell you right now, I would like to tell you right now that there's a lot of published literature saying that the application of compression therapy is key in healing a stasis ulcer. Meaning to say that if you have a wound in the leg and you have edema as well, especially which is usually the case, you have a venous insufficiency or you have a venous disease, compression therapy is key in healing your wound. In other words, you may not be waiting for closure. If your thought process is, I want to close the wound first before I'm going to wrap, that is no longer the standard practice at this point, because a lot of studies had shown that people who received skilled wound care in combination to compression therapy, they healed their wound faster. So if you are a patient watching this, do not hesitate or do not make a lot of excuses when your clinician put the compression wrap on your legs when you still have wound. Okay, some patients, and sometimes I don't blame it. All you need to do is to explain and make you understand. I have noticed. I'm in the area of or field of wound management for some time, and one of the things that I notice is that you come and you have ulcer in your leg, and I debride your wound, I clean your wound, and then I dress it, and then I wrap it. Okay, so what you would do, you walk out of the clinic, you go to your car and remove the compression because you think that it's irritating. There are so many reasons. Or you go to your house and then you're gonna call the office saying that, oh, I have excruciating pain, I have tingling and everything like that. And then you remove the compression. And you come back after a week and there's no change. So what kind of change are you expecting if you remove the treatment? The dressing that I place or the debridement that I place is just one shot treatment, meaning to say that that is the treatment that you received when you were at the clinic. Once you get out of the clinic, you go home, you want to have a 24/7 treatment, and that is the compression therapy, because the compression therapy is managing the cause of the problem. It's the congestion, it's the accumulation of fluid that has caused the problem in your legs. So therefore, if you want to solve the problem, you need to identify the problem and manage the problem, which is the swelling or the edema. So at this point, I am advocating So, in relation to this, people would always say, "Oh, not too tight, not too tight." Don't you know that if your clinician uses a Doppler, a handheld Doppler, if you happen to be a patient of mine, you know that most of the time I use a Doppler and I would listen to the blood vessel uh, at the uh, top of your foot and also at the inner side of your ankle. That's what we call the dorsalis pedis artery and also the posterior tibialis artery. There's one of the end uh, arteries or end blood vessels in the arterial system in the body. And the purpose of me doing that is to listen to the type of waveform that you have. Sometimes you don't have, well, if you are a clinician listening to this, there's what we call the monophasic, we have the biphasic, and you also have what we call the triphasic. So usually when you hear a monophasic waveform, that's an indication of that there is an arterial compromise. So however, if you notice, if I put a cuff at the calf area, or a cuff, cuff, at the calf area, and inflate that, and then listen to the circulation to a Doppler, you notice that it takes at least 80 millimeters of mercury for me to obliterate the pulse, for me to obliterate the sound. And don't you know, ladies and gentlemen, that the compression therapy, okay, like the Uniboot and whatnot, Coflex, 2Press2, the Coban 2, and or even the one that we use in lymphedema, the multi-level layer of compression. I don't think that there's a clinician that uses a compression that exceeds 50 millimeters of mercury. So with that concept, okay, I don't really think that there's form of compression and that we use in the clinical practice that could actually occlude or cut your circulation. Because I repeat, like what I said, it requires at least 70 or 80 millimeters of mercury to obliterate that sound, to obliterate or cut the circulation. And you can prove that next time you get a Doppler, you put a cuff at the, a blood pressure cuff at the calf area, and you inflate that. It requires at least 80 millimeters of mercury for the sound to get obliterated. So, okay, if you're using only like 20 to 30 millimeters of mercury, or 30, most of the time I just use 30 to 40 millimeters of mercury compression. So it's not enough for me to obliterate that the blood vessel or the flow, especially when you come in at the later stages of your edema, or if you have venous insufficiency and you have this for a while. Okay, don't you know that venous insufficiency will always have a lymphatic component, meaning to say that the transporter of the protein, which is the lymphatic system, are not also functioning. So therefore, there will be an accumulation of proteins in your skin, and that would make your skin fibrotic, meaning to say that it makes it hard and thick. And in the presence of those accumulated proteins there, they also hug the water molecules. So therefore, it doesn't matter if you're being diuresed or you are being prescribed with diuretics, that swelling will not go away because the water molecules are being hugged by the proteins molecules. And that being said, even if I exert 30 to 40 millimeters of mercury, it's hard for me to press or compress that tissue because it's fibrotic, it's hardened. It's also because of the presence of intervening water, intervening fluid as well. So So my point there is that if you're a patient watching this, the last thing that you would think is that, oh, it's too tight, it's cutting my circulation. That's the usual word that I usually hear. And see, the thing is, the moment you start thinking about that when you have your compression wraps on in your legs, okay, it will instigate a lot of anxiety, and then it will make it real, and then you'll be anxious and you cannot sleep, and it's disrupting your quality of life, and then everything will now be blamed on the compression. So therefore, I would like to assure you, okay, well, I can only talk about the way I do it, okay, or any skilled clinician, any wound care specialist, any physical therapist who is trained in wound care, any nurse who is trained in wound care, any doctor who is trained in wound care, of course, if they are, everybody who bears a certification in wound care also underwent training on compression. So I don't think that there is anybody that will be able to really cut the circulation using the compression materials that we are using in the market right now. So that being said, it doesn't mean that you have the freedom. I just wanted to make sure that you have the freedom to get any type of compression and wrap your legs the way you want it. That's not what I meant. Okay, what I meant is that compression, when it's done properly by a trained professional, okay, cutting the circulation, or the concern of the circulation being cut, should be least of your problem if you are a patient watching this. I hope you learned something today. As usual, I always encourage you to seek for professional advice. Do not change any of your regimen based on what you see on social media or what you see on YouTube or what I say here. Okay, this is just a guide for you. You always get in touch to a skilled professional, a healthcare professional, so that you will be evaluated and you will be treated properly. I hope that all makes sense to you. Look at the background, it's so beautiful. And I hope to see you in the new year. Okay, God bless.